My name's Jane Maloney, and I founded the Diversity Committee with Sharon Davis Murdoch, so I'm just really proud to say that, you know, we didn't dream 3 years ago that it would come to where it is now. Just wanted to say that the design that is on the front of your notepad and is on the beautiful T-shirts has a story. And as so many people have asked what it is, Sharon asked me to explain what it is. When we started the committee and we decided what we were there for and why we wanted to do this work, we felt that one of the most important things we can do is say who we are. And so we did a little exercise which brought out our characteristics, and they're the words that are in the circle on the page. And from those characteristics, we took the idea of a totem pole, and a woman called Pam Jones, who was one of the members of the committee at the time, drew the animals that represented us as the first 10 members, of whom 5 are still in this room. There's Erin, who's around there somewhere, and me, and Jim, and Sharon, and Toyin. So it's great to see that there's still 5 faces, but 5 of us are 5 of those animals on there. And it really was intended to show that within our diversity, there is diversity, and from our diversity, we also have points of sameness and similarity with everybody else. So that's what the design's for. Thank you.
Mine is more of a comment. I'm Donna Smith, and I'm with Cancer Care Nova Scotia, and I just wanted to comment on the research, Dr. McKenzie, that you mentioned in the Prestons. Now, the unfortunate part about that research was it was based on postal code. So how accurate is that? So, and that speaks to the need for collection of health status data.
Hi, my name's Bill Knowlton with the Annapolis Community Health Board, and something I want to bring up, and if I'm not the most politically correct person, you'll have to forgive me, it's not something I'm known for. But to address our 2 keynote speakers, thank you so much. Where I'm coming from, when we talk transgender, gay and lesbian, immigration, refugee, in Halifax itself, they do vote in those barriers. I'm from a rural community, 150 to 400 people maximum. I'm wondering if you could speak to the challenges that they face, because it's much different. At least the words are used here. You hear them all the time. You have like-minded. It's preaching to the choir in this room. I'm a white, heterosexual, middle-class man, and I have people coming to me for help. What can I do to assist them? Because it's not something I've ever experienced before, and we have very little resources. So what can we do to assist in championing this?
Rural healthcare is a big challenge in terms of people of diverse backgrounds. One of the things that we try to do is encourage them to be connected to an online community, that there's a lot of resources in terms of for transgender people online. I think that's one thing. Another thing is to see if we can educate the healthcare professionals. And the third thing is to, as you saw in the study, that the family is such a kind of pivotal point, or in terms of a protective factor. So if we can work with the family to kind of support the child or the adolescent or the adult and the family members, that's the best thing that we can do.
2 points. The first point is about the research in Preston. The research in Preston was far from perfect. It was the only research I could find, and there are problems with it. But it makes you think that there might be a problem worth looking at. With regards to the rural communities, I really do think that an inequity is an inequity, and I think that rural communities get a very, very, very bad deal in the way that services are structured. And it speaks to a question about whether we think that health fits into a human rights perspective, or whether we think that economics are more important. If we think it's a human right, then we should be looking at how we structure the health services services. So very much as, just say, for instance, the small example I showed in downtown Toronto versus the outskirts, we put all the hospitals downtown and we expect people to get there. We need to think of how we, we change our health service structure so that we meet the rural needs. There is a rural caucus around Canada trying to think this through. But at the moment, there's certainly a political battle to get the money out from the cities into the rural areas to meet people's needs. The wonderful thing about some of the work that's happening out in Saskatchewan at the moment is they're thinking about rural communities and they're thinking about diversity in rural communities, and they're thinking of new service models that will increase the effectiveness of services out there. But at the moment, we're doing too little, and we're causing, and that I think is problematic.
Primary health care. And so, of course, our focus is really about how do we build capacity within primary health care around diversity, around how do we get access and coordination to a lot of the services that come with our populations that have multiple chronic diseases as across a continuum of care. So I'm looking to see, in terms of your understanding of how we can better work with our primary health care partners, our practitioners within communities, to understand that it's not necessarily about one chronic condition, but it could be multiple chronic conditions that require a lot of navigation. And just wondering if you have any insights to offer us around how we can do that a little bit better.
So the question is, how do we get primary care physicians to realize that there are multiple problems? Clinicians, practitioners. Well, it's a difficult one. At the moment, there has been some work that's been done in McGill, and they have been trying to improve the access of the information on diverse populations and multiple disadvantage and multiple diseases. And they've produced a whole bunch of data, information sheets and things like that. But there's been quite a lot of research recently that shows that websites and bits of information don't really change practice in primary care. And the primary care clinicians and physicians and practitioners who we've spoken to want somebody to be there to help them to do things. So you probably know that practice change has three key elements. One is the knowledge, the other one's the attitudes, and the last one's the skills. And it's the skills that really change outcomes, but the skills take coaching. It's possible all the information's there, but the question is, how do you get the people to the primary care clinicians and get them to do it? And we were talking earlier about the fact that it's quite difficult to get them to do it because it doesn't actually pay. And so when, previously I talked about this idea that there's got to be a change in the environment in which care is produced. The best way that we've seen of getting primary care practitioners to change what they do is financial levers that are external. And financial levers that external change the way they want to do things, and then they start asking people in to help them learn how to do things, and that sort of push rather than a pull seems to be what works.
I have a couple of questions here from the audience. One is to Sibel or others that were on that panel. Have things improved, gotten worse, or are about the same in regards to homophobia in our society and the effects on the LGBTQ community?
Certainly things have gotten better. I guess that my sort of ramble this morning after I walked off stage, I wish I'd made 3 points. One is about the privilege piece. The other's about the psychic work it takes to be different around sexual orientation, how much work it is. So, for instance, when I started working at the hospital, I was already 40, but I knew that I had to have a 5-year plan. I never named myself as gay. I wanted people to know my practice before they knew me as a gay man. And so, well, that's a lot of work. And so in every room I walked into, I was always, maybe it's like the piece of paper that Jim Guthrow asked you to have in your pocket. I didn't bring it up. So the psychic work that people have to do. And and the third thing was the intersectionality piece. I wish I'd said more about that. For instance, Toya from Nigeria, your story, and not to diminish it at all, but so if a son or child or your husband that came with you were coming out as gay, then that adds another piece, and that's what it's like. In relation to the intersectionality of gay. Sharon Davis Murdoch promoted a Black and Out last year. It was excellent, and we talked about what it means to be African Nova Scotian and coming out as gay or lesbian. I mean, I'm old, and that would not have happened a few decades ago. None of it would have happened, you know. So, yes, things are getting better. In healthcare and in our daily lives, they're definitely getting better. It's still, you know, I'm in a relationship with another man. I try not to have an argument at the grocery store. We look like a couple of fags, you know. You know, so some things aren't better. I was in a marriage with a woman, and when I was with a woman, we used to argue at the grocery store all the time, you know, but I don't argue with my same-sex partner. So not everything's better, but some things are better. But really, Gail Knutsen's piece about transgender health is really something we all need to pay attention to, because it's not going away. The emerging challenge for all of us to think about diverse, variant gender expression. And as Gail said in her talk, it's not male or female. The new categories that are going to come out from the World Professional Association and in the DSM are going to promote a gender variant spectrum. And that's hard to get our heads around. It's just opening up more and more spaces. So that's a long answer, but yes, things are improving.
My name's Lucas. I'm the chair of the Nova Scotia Rainbow Action Project's Health Committee. So I just had a question about attitudes of healthcare providers. We get a lot of questions and people that have had incidents and things like that sort of prompted me to ask this. So how do we address attitudes of clinicians in general? You know, one way we do is we change the curriculums of the colleges and the universities that are pumping these people out. So, you know, that's certainly a positive influence. Additionally, I think somebody could definitely argue that younger Canadians in general seem to have more open ideas about issues of diversity and a whole broad range of topics that sometimes, unfortunately, older Canadians do not. Things like that. But what we hear a lot about is older practitioners or just practitioners who would be considered old-fashioned, who are already there, are already past all of that training, you know, are well beyond any sort of interventions from an educational perspective that is mandated to them anymore. You know, how do we change the attitudes of these people who make up a huge bulk of our healthcare workers? And, you know, how do you physically change someone's attitude you know, and this can be regards to anything. This can be regards to, you know, issues of racism and homophobia and so on and so forth. You know, transphobia, of course. How do we address that? Yeah, I think it's pretty straightforward.
I believe it's through education, and in terms of education, giving people the background knowledge to, for example, conferences like this, also doing manuals in terms of like the standards of care, and giving people access to those like online that are free, that they don't have to go out and get them. The second thing is studies that came out of the 60s, and it was talking about diversity in terms of in psychology, and there's one called the contact hypothesis, and it was if you have contact with a person that is different than yourself, like whether their physical abilities are different or whatever, the more kind of engaged contact you have, the more likely your more likely your attitudes are going to change and your practice. But that has to be like, you have to spend time with that person. So when we were talking yesterday in terms of primary health care, and this goes back to your primary care physician's question, that there's a, like, one physician will have one trans patient in their practice and then learn about transgender health care, and they're like, oh, this isn't that difficult. And then they'll have more people and more people and more people in their practice. So it's providing the knowledge base and then having them willing to accept the person into their practice, and also providing supervision, as in they can go to a group of professionals that they can talk about the challenges they're having in terms of health care, like access to care, and so helping their patient navigate the system.
Changing attitudes is difficult, but it's not impossible. But the first thing you need to know is where the attitudes come from. So if the attitudes come from a feeling of helplessness, so you don't feel that you can deal with the situation, then that's something you might want to do something about. If the attitudes come from, other places, you've got to sort of isolate the attitude, and then if it's education, it's education. If it's exposure, you have to expose the person. If it's a skill development, you have to do the skills development. But it depends where the attitudes come from. Some of the attitudes are there because we allow them to be. So cultural competence didn't really exist before the 1970s. It didn't exist because it came out of the States, and at that time, still up until the 1970s, the Jim Crow laws were still really being in effect. Therefore, prejudice was okay to a certain extent. So you have to really do an analysis of where they're coming from. Otherwise, you can end up spending a lot of time trying to change attitudes and not get very far. In fact, some people have started saying, we may not be able to change attitudes, but we may be able to change what people do. So we can't actually change their attitudes, but let's change the behaviors. So even if they are discriminatory in thought, as long as they're not discriminatory in action, then that's okay. So there are loads of different things you can try and do to try and move things forward, focus on the results and change a practice rather than just trying to change the attitudes.
I think to answer your question, the last question, I think accountability is really important here. We can have all this education, but if there isn't some kind of measure and some accountability, then for naught, all of it, really. Some kind of surveys need to go out on how people are being treated in these places. There needs to be something like that done, I think. If we have the will, then we would have accountability.
With that accountability comes policy and procedures. So healthy public policy, that one of the best way to impact belief systems across a population or a generation is through policy. And so I'd love to hear what kind of policy options might be available.